In this video, I'll show you how I like to read an MRI of the brain with and without contrast. So remember, there's a bunch of different ways you can do this, so these are just some suggestions you may choose to incorporate in your practice. So I'm pretty lazy and I like to just look at the images, the sequences in the same order that the text given to me. And this way I also don't miss any sequences that they might have sent through. Okay, so first things first, they give us this scout. It has a really big field of view. So every once in a while you can miss a neck mass or something like that, right? Or a mass in the cervical spine on the scout images. So I just quickly look through the scout images, make sure I don't miss anything here. And then now I go to my T1 sagittal. Okay, so T1 sagittal, I look at the cervical cord, I look at the brainstem, I look at the cerebellum. Always make sure that there's no Chiari malformation or tonsillar herniation. Look at the pre-pontine cistern. I look at the suprasellar cistern, make sure that it's present, not effaced. I always take a look at the pituitary gland and the cellular suprasellar regions, make sure there's no mass. Look at the thalami, look at the fornix. I look at the corpus callosum, and I look at the cerebral hemispheres. And I take a quick look on both sides, and then I usually go from central to peripheral. So more peripheral, I see the cervical spine, so I take a look at the Bayesian dental interval, the lannodental interval, and the upper cervical spine. I also take a look at some of the soft tissues here. Like you can see the oral cavity here. And I take a look at some of the other soft tissues around. Great. So that's the T1. A lot of things that you can see there. Okay, so now I go to the DWI. So I usually start central and I go peripheral. So I look at the medulla, I look at the pons, I go up slice by slice, look at the midbrain, I look at the thalami, and I look at the bilateral basal ganglia. And I also look at the structures which are supposed to normally be a little brighter on DWI, like the posterior limb of the internal capsules, the lateral corticospinal tracts. Usually they're a little brighter, so I make sure that I see them and I don't mistake them for an acute infarct. All right, and then after that I look at the right frontal lobe, I look at the left frontal lobe, then look at the the right temporal lobe, left temporal lobe, look at the left parietal and occipital lobes and left cerebellum, look at the right cerebellum, right occipital and parietal lobes. And one thing I also like to do with the DWI is to look at the calvarium, because usually the calvarium is black. But every once in a while you can have a calvarium metastasis, and those tend to be hypercellular. So if you see something bright on the DWI, it means that it probably needs further investigation on the other sequences. And so this is a nice way to screen for any calvarial lesions. I look at the skull, calvarium, frontal bones, occipital bones, etc. And after that, I could take a look at the soft tissues using DWI. See over here, I can see some of the lymphoid tissue in the oral pharynx and the nasopharynx, and I look for any enlarged lymph nodes. Sometimes you can see a parotid mass that is bright on DWI. All right, so that's the DWI. And I get the ADC map right next to it. So usually if there's nothing on the DWI, then I pretty much just ignore the ADC map. But if I see there's something abnormal on the DWI, like a bright spot, something that I think is an acute infarction, then usually I try to correlate that. This little shortcut key here that I use to correlate it with the ADC map to see if what is bright on DWI is in fact dark on ADC and is diffusion restricting. All right, and sometimes if the patient's moving around a lot and you don't get a T2, the ADC map can be a poor man's T2. All right, so next sequence. So in this case, the tech gives us this sequence here, which is basically the opposite of an ADC map. I just ignore it. Over here is the susceptibility weighted imaging, SWI, or the SWAN, whatever you want to call it. Basically, it's good for looking for blood and for calcification. So I look through the brain centrally, the deep gray matters, and the bilateral cerebral hemispheres. Look on each side, up and down, bilateral cerebella. Great. And every once in a while, if you have an artery that's clotted off, or cortical vein thrombosis, it can actually look really dark on the SWI. Okay, next. And again, this is basically they gave us 2 SWIs, and take another look through it, make sure I didn't miss anything on the other SWI. This over here is the phase contrast imaging. I pretty much just ignore it, but basically it's information that's derived from the SWI. Next sequence. So we have the T2 flare. I think the DWI and the T2 flare are my 2 favorite sequences on an MRI of the brain. So basically, I look at the medulla, I look at the pons, remember I start out central and I go peripheral, and I look at the midbrain. Okay, look for any kind of signal abnormality. Oftentimes in older people, you can see some central T2 hyperintense signal within the pons related to, chronic small vessel disease. Okay, and then after that, I look at the basal ganglia. Again, the deep gray matter structures and all gray matter structures should be bright on T2 flare and on T2, while the white matter should be dark. Okay, and then after that, after clearing all the gray matter structures, including the thalami and basal ganglia, I look at the white matter. It should be nice and dark, like the frontal white matter on each side. Okay, I look at the corpus callosum. I don't want to miss a white matter lesion there. Look at the bilateral temporal lobe regions. Okay, then look at the cerebellar white matter, parietal occipital lobe white matter, and I look at the left side, the parietal occipital lobe white matter, and the cerebellar white matter. Okay, now I clear the white matter. Now I want to focus in on the gray matter. I look at the gray matter, the sulci, and the interface between the cortex and the calvarium, looking for any kind of signal abnormality in the gray matter, like a mass or something like that, looking for any kind of hyperintensity within the sulci, which could be subarachnoid hemorrhage or it could be artifact, among other things. And you can also catch a subdural pretty well on a T2 flare. Usually they're bright, they're located between the cortex and the inner table of the calvarium. So I look at the frontal lobe on the right, frontal lobe on the left. I look at the left temporal lobe region, right temporal lobe region, right parietal occipital lobe region, right cerebral hemisphere. Again, looking at the cortex, looking at the sulci, looking for any kind of sulci, hyperintensity in the sulci, looking for any kind of thin subdural hematoma, which can be subtle, and looking for any kind of cortical signal abnormality. All right, and that's the T2 flare. After that, we go to our T2. So I kind of read it like a CT where I start centrally. I look at the size of the ventricles, look at the occipital horns. Sometimes you can see blood layering inside the occipital horns, so you definitely want to watch out for any blood there. And you can also sometimes double check the occipital horns on the T2 flare too for any layering of blood if you think you see something on the T2. I look at the temporal horns of the lateral ventricles, make sure they're not dilated, which can be seen in the setting hydrocephalus. I look at the frontal horns, okay, and then I look at the third ventricle over here. And then after that, I look at the suprasellar cistern. Okay, make sure that you have CSF there. CSF can be effaced when there's severe cerebral edema or a mass. And then after this, I look at the internal carotid artery flow voids. See that? There's supposed to be a flow void of the right internal carotid artery along its petrous segment, along its cavernous segment, and in the communicating segment. Make sure there's a nice flow void. Look at the MCA for a nice flow void. And of course, if I don't see a flow void, the vessel might be occluded. So I look at the left MCA flow void, the left ICA flow void, in the cavernous segment and also in the petrous segment. Every once in a while, you can catch occlusion of the ICA on an MRI because of loss of that flow void. Okay, and then I look at the premedullary and prepontine cistern, and I look at the vertebral artery flow voids. Make sure that they're black. make sure I see a basilar artery flow void. You want to make sure you don't miss an occluded basilar artery. Okay. And then I look at the ambient cistern. I look for any kind of mass. I look at the size of the fourth ventricle, make sure everything's appropriate. And then after that, I look at the brain parenchyma on T2 flare. Generally, on T2 flare, you get less artifact in the posterior fossa. So if we compare these two here, see this thing here looks a little bit blurry, whereas over here it looks a little sharper. So sometimes you can catch lesions, especially in the posterior fossa on the T2, a little more easily than on the T2 flare. So let's go back to the T2. I look at the medulla. I work my way up to the pons. I work my way up to the midbrain. Okay, look for any kind of signal abnormality, especially anything that's T2 bright. Sometimes you can catch a little, lacunar infarct in the pons, or chronic white matter change within the pons. Then I look at the deep gray matter structures. I look at the thalami, and I look at the bilateral basal ganglia, the caudate, the putamen. They should look bright on T2. Okay, now that I cleared the gray matter, I can take a look at the rest of the cerebral hemispheres. Usually with the T2, I kind of look at the cortex a little more, and this is because when you have encephalomalacia, basically brain replaced with water, it looks really bright. It looks like CSF. And sometimes you can catch a little bit of encephalomalacia or a chronic infarct on the T2 more easily than a T2 flare. So I look at the right frontal lobe, the left frontal lobe. I look at the right temporal lobe region, left temporal lobe region, work my way up. Look at the left parieto-occipital lobe region and the left cerebellum. And look at the right cerebellum. And again, sometimes you can catch these little tiny lacunar infarcts in the cerebellum that you can't really see on the T2 flare, but you can on the T2. Okay, and then look at the right parieto-occipital lobe. Great. And after that, I look at the soft tissues on the T2. I look at the scalp for any kind of soft tissue squalling in the scalp. Okay, I look at the scalp posteriorly, laterally, anteriorly. After that, I look at the orbits. I look at the globes, make sure they're intact. I look at the orbital fat. Great. And then I take a look at the paranasal sinuses. All right, make sure that they're clear. So you have some trace maxillary sinus disease bilaterally. And if I look at the paranasal sinuses, I also want to look at the mastoidea cells. Check whether or not there is fluid in the mastoidea cells. Okay, and finally, I can look at some of the neck deep space soft tissues. So in this case, I can look at the masticator space here. Make sure I don't see a mass or infiltration of the postantral fat. Very important to look at the nasopharynx. Sometimes you can catch a nasopharyngeal mass on an MRI of the brain. And look at the parotid glands. Sometimes you can see a parotid mass on an MRI of the brain. And after that, I'm done with the soft tissues on a T2. All right, the T1 axial, usually I spend 2 seconds looking at it. I just scroll through and looking for anything that's really bright. Things that can be bright on this T1 axial could be like a lipoma. It could be hemorrhage can also be bright. A little subdural can be bright. Intraparenchymal hematoma can be bright. Sometimes melanoma mets can also be bright too. But usually 99% of the time I just scroll through in 2 seconds. Since this is a study done with and without contrast, we also do a T1 FAT-SAT. So it's the same as the T1 over here on the left side, except we do a FAT-SAT sequence. So we make all the fat look dark. Okay, and so this, I just take a look at it in about 2 seconds. Make sure there's nothing that's really bright, like a subdural or intraparenchymal hematoma. All right, next. Now here we have post-contrast images. So this over here is a post-contrast images done with a 3D technique. So they're high-resolution images. We use isometric voxels, and so the text can actually reconstruct these. Here you have an axial, which is then reconstructed into a sagittal and also into a coronal. And they also happen to do another axial too. So this is just like a repeat. So let's take a look here. So on the post-contrast images, usually I first look at the venous sinuses to make sure there's no venous sinus thrombosis. I look at the superior sagittal sinus. I look at the straight sinus. I look at the bilateral internal cerebral veins, make sure they're all patent. I look at the transverse sinuses on both sides. I look at the sigmoid sinuses, and I look at the jugular bulbs and internal cerebral veins. I look at it on each side. And basically what I'm doing here is making sure there's no venous sinus thrombosis. All right, great. Now I look for any kind of abnormal enhancement. So I start centrally and I go peripherally. I look at the medulla, I look at the pons, midbrain, thalami, look at the basal ganglia, look for any kind of abnormal enhancement. Then I look at the white matter for any kind of abnormal enhancement. So I look at the frontal lobe white matter on each side. I look at the temporal lobe white matter on each side. And finally, I look at the cerebellum on each side and the bilateral parotoccipital lobe white matter on each side. And finally, I clear the gray matter on each side. And usually I look extra careful if they're, looking for subtle mets in the brain. So I look at the bilateral frontal lobes, temporal lobes, parietal lobes, occipital lobes, and back down towards the cerebellar hemispheres, looking for any kind of enhancement, which can be kind of subtle sometimes. Sometimes you can see very, very small mets on these 3D images. Okay, these 3D images are also, as you can see here, reconstructed as sagittal images. Take a quick look at the superior sagittal sinus, straight sinus, internal cerebral veins, transverse sigmoid sinuses. Make sure I don't miss venous sinus thrombosis. Great. Again, I take a look at the midline structures, make sure there's no QRE malformation. Look at the configuration of the cerebellum and the cerebellar vermis and the brainstem here. And I always take a careful look at the pituitary gland and the cellular paracellular regions for any kind of, cellular mass, such as a pituitary adenoma. And then I look around for any kind of abnormal enhancement, and I take a quick look at the clivus and at the upper cervical spine for abnormal enhancement. Great. Coronals, usually, I just look through this really quickly because I already looked at the same data in axial and sagittal. So I just take a quick look, make sure I don't miss any kind of abnormal enhancement, and then I go from there. Over here is the 2D post-contrast. So let's compare the 2D with the 3D. This is the 3D down here. This is the 2D up here. So the 2D is actually done at a later time point than the 3D. So if you're looking for enhancing metastasis, you actually have more time for these metastases to soak up contrast on these 2D images than on 3D images. So sometimes you can see an enhancing metastasis on the 2D that you don't see on the 3D. On the other hand, for some very small masses, since the resolution, spatial resolution is higher on the 3D, sometimes you can see a tiny little metastatic focus on the 3D that you totally skip over, that you can't see on the 2D. And so I think both these sequences, the 2D and the 3D, are complementary, and I look at both. And if I see a finding on one, I usually want to try to confirm it on the other. So this is the 2D. I look centrally in the brainstem, thalami, deep gray matter, basal ganglia, and finally I look at the bilateral cerebral hemispheres, looking for any kind of abnormal enhancement, anything I might have missed on the 3D. Okay, so I look at the parietal occipital regions, bilateral temporal regions, and then I like to use a sequence to look at the bone to make sure there's no enhancing corporeal mass. Okay, and I take a really quick look at the soft tissues, make sure there's no abnormal enhancing orbital mass, make sure there's no abnormal enhancement in the masticator space or an enhancing parotid mass or enhancing nasopharyngeal mass. And also, I usually look to see that the nasal mucosa is nice and enhancing. If the nasal mucosa is darker diffusely than the white matter, that usually means that the tech didn't give contrast or the contrast infiltrated. So make sure that the nasal mucosa is nice and bright. If there's some focal areas of mucosa that's not enhancing, sometimes it can be fungal rhinosinusitis. You don't want to miss that either. And I look at the soft tissues, make sure there's no abnormal enhancement. And then, last but not least, I get subtraction images. Basically what they do is they get the, let me pull up the images here. They get this image here, which is the T1 fat-sat precon, and then they get the post-con T1 fat-sat, right? So they take the post-con images and they subtract it from the pre-contrast images. So basically anything that's bright on this sequence is something that enhance. And so usually if this thing is, if the T1 post-con is normal, the subtraction images are going to be normal too, because there's nothing abnormal that's enhancing. So I take a quick look, make sure I didn't miss any kind of enhancing mass on the post-contrast images. And I just take a quick look through these subtraction images. And that's pretty much it.